So what I'm gonna do is try to give you some tips and pros as to how to do an exam. Um, I did show some videos as to how to do the key exam findings, but let me start with a carpal tunnel exam, Tinel's. So can I see? Yeah, roll that off. So what you do is you take the thumb and the pinky and you oppose it, and then you bring your wrist up, and if you can see here, you have the palmaris longus tendon, but 20% of patients don't have a palmaris longus tendon. So if you don't have a palmaris longus tendon, what you can do is just sort of tap all around the midline and see if you get a Tinel's. And so the median nerve kind of lives right there, radial to the palmaris longus tendon, and so I will tap there. Okay. The sensitivity of Tinel's is not great, but what I've found is that sometimes when I do a Tinel's to increase my sensitivity, can you relax your hand for a second? I actually compress here like at Durkins, and then I will do a Tinel's. And then that has actually increased my Tinel's for my compression neuropathies. The reason I do that is I think it works. It's kind of like a double crush phenomenon. So I'm basically compressing the nerve here and also like tapping and compressing the nerve here. And so I think that increases my Tinel sensitivity. For carpal tunnel syndrome, so I will ask them if for numbness in the radial digits. A lot of patients will actually present with numbness in the middle finger before they feel it in the thumb. So you don't have to have numbness in all the digits. It could actually just be sort of like one digit. The reason the middle finger tends to be earlier than the other fingers because it's a more superficial fiber on the median nerve topography. And so as you have external compression, the more superficial fibers get compressed. That's why might present with a middle finger numbness. So I will ask them about numbness. My motor testing for carpal tunnel is I will have them, I tell the patients, make a 7 like this. And a lot of times people will extend their finger. So I'll grab their finger and leave it like, put it in the plane of the index finger, okay? And you have a very strong, look at this. This is like great. This is APB muscle, okay? This is the abductor pulsus brevis muscle. And I have them resist and I'm gonna push. And this is where the APB muscle is present. Just to note that some patients will have a congenital sort of like a hypoplastic APB. So they're really strong, but you might feel a divot. That doesn't mean that they have carpal tunnel. They might have a hypoplastic APB, which is very rare. And some patients who have CMC arthritis, when they have dorsal radial subluxation of the metacarpal, they'll actually create a divot. When you look at it, it might look like they don't have an APB, but when you test them, they're strong, which means that they don't have APB atrophy, okay? This is like advanced findings. So advanced physical exam that you can do, you could have compression of the median nerve at the carpal tunnel, but more rarely you could have actually compression of the median nerve here, more proximal. And so the way you could differentiate this is that patients who have carpal tunnel syndrome, they may have sensation here, which is the palmar-cutaneous branch of the ulnar nerve, which actually splits up about 5 centimeters proximal to the wrist crease. And so if they have sensation here, they may actually have proximal median nerve compression. And the motor testing for that is you actually have to test the proximal muscles innervated by the median nerve, which is the muscles innervated by anterior interosseous nerve. That would be flexor pulsus brevis, bend here, and then flexor digitorum profundus to the index finger. So they will present patients with proximal median nerve compression or carpal tunnel syndrome will present with numbness in the hand, but that's how you differentiate if they have it more proximal or distal. Okay. Next, since we're talking about compression neuropathies, I'm going to go to the elbow. We'll talk about the cubital tunnel syndrome. And so if you feel here, you have the media epicondyla, the ulnar nerve lives right there behind the media epicondyla. So that's what we call the funny bone nerve. So to increase your sensitivity, you can actually flex and tap here to see if you have a Tinel's. And then you could also do an elbow hyperflexion test. You just kind of hold them like this for about, up to a minute. But if they start having numbness in the fingers, then that's a positive test. One thing about the elbow hyperflexion test is if you, a lot of patients will tend to bend their elbow, their wrist too when they do this. So the problem with this is that you may actually also compress the median nerve. And so what I do is I try to keep the wrist straight. Okay. Next thing is I'm going to do motor testing for the cubital tunnel, so ulnar innervated muscles, right? And so for the ulnar median innervated muscles of the forearm, it's what I test is the flexor digitorum profundus to the ring and small finger. So for a long time, I used to do this testing. Can you bend, hold it? But I have mechanical advantage, so you're really strong. So I can't break you, but a lot of times I could break people, you know? I just can't, they can't hold it because I have mechanical advantage. And what I found easier to do is I put like 2 fingers here, okay, make a fist, okay? And then I try to peel off their finger. And a lot of times make a strong grip. Yeah. So if their pinky doesn't reach, then I'll use 1 finger. Okay, make a fist. Okay, tight, and then I try to break it off. You know, and so that's how I test FTP. Next thing is I'll have them open and close. Open and close. That's also how you test for Wardenberg's. If they can't bring their finger in, or they just shake and it just comes out, that's a positive Wardenberg's. The test that I showed is the first dorsal interosseous test for ulnar nerve. The way you do it, you actually have to bend the finger about 30 degrees and then abduct it. And I actually palpate, which is this muscle here next to the metacarpal right there. Okay, hold it there, hold it, don't let me, and then I'm gonna push and resist. And this is how I test for first dorsal interossei. And the question is, why do I have to flex it? The reason we have to flex it is if you don't flex it, sometimes they're weak in their first dorsal interossei, and when we try to test abduction, they might actually extend use their extensor to resist that, which is a radial innervated muscle. Okay. We discussed froments, which I showed that video. Basically, this is the key pinch, and I have them hold it there, and I'll have a piece of paper. I usually use my badge because if they're strong, they'll rip the paper. I use my badge. When they have a positive froments, I usually say, "Don't let me win," you know. And most people are competitive, and so when they can't hold my badge, what they'll actually hyperflex their MP joint to hold the badge. Okay, so that's carpal tunnel and cubital tunnel. Next, what I want to talk about is talk about trigger finger. And so the trigger finger, if you look at this crease, this is the palmar digital crease, and this is the distal palmar crease. And so the A1 pulley is in between those 2 creases. Okay. And so that's also where I inject for my trigger fingers. In the thumb, it's at this crease. This is where the thumb A1 pulley is. And this is also where I inject for trigger finger. One thing about the thumb is that if you look at it, sometimes people think that the midline is more radial. You have to be cautious about that, but because that's where your radiosensory nerve crosses. And so that's not where you want to inject. When you're going to inject a trigger thumb, have the patient flex and extend, and you could feel the flexor tendon, and that you mark your midline. And so the midline is actually a little more ulnar here. Okay, so that's trigger finger. The next thing I want to talk about is Dequer veins. So Dequer veins, if you could actually palpate, extend your thumb. So you could actually palpate the extensor pulsus brevis here. And then usually they have the fibroosseous tunnel is about, I would say from the wrist crease, about centimeter proximal. And if you push there, they're gonna have pain, okay? And so the test that we had discussed was the Finkelstein's test. And I would ask the patients to sort of bring your wrist to your pinky side, and I'll grab the thumb and I'll do the Finkelstein's test, okay? The next test is the ICOF test. Put your follow what I'm doing. Put your thumb in, and then your fingers, cross your fingers, and then you grab the hand and you bring it down. That's the eye cup test. Did that hurt?
Yeah.
Okay, right? That's a positive test, right? Now go this way, and then does that hurt? Not as much, right? Yeah, so the eye cup test tends to be higher false positive. Okay. Should we do it again? Show your face? Yeah. Okay. Yeah. So that's for dick remains. Like I said, you can inject straight down. What I like to do is I will actually have the patients put their hand over the edge of a table, and then have them bring it ulnarly like this. I'll inject 0.5 cc's, and I like to inject this way. I feel like there's more room for me to inject my the first dorsal compartment. And just remember that the first dorsal compartment travels in this oblique direction. It doesn't go straight up the radius. It actually goes in these oblique directions, which in some patients you can palpate, and they'll inject, and then once in a while you'll hear a very satisfactory pop, or you actually feel it fill up, either up the thumb or down the forearm. Okay, so that's deeper veins. So we went over carpal tunnel, fetal tunnel, deeper veins. Since we're talking about tendinopathies, let's also talk about tennis elbow. So for tennis elbow, I usually start with flexion. I'll palpate the lateral epicondyle. I find it easier to palpate the lateral epicondyle in flexion than in extension, personally. And then I feel the lateral epicondyle, and I'll usually go loop slightly distal and slightly anterior and push there. That's kind of where the ECRB inserts. And then I will extend them, and I'll push, and I say, does that hurt? And they'll say yes a lot of times. Next thing, I do the Cousins test, and I say, bring your wrist up and don't let me win. And I'll do resisted wrist extension, and they'll have pain here where my thumb is, okay? The last thing, the other exam that I do is I will have them put their arm flat, and then bring your middle finger up, and I will push, and they will have pain here. And just as a control, if you guys want to do try this test, is have them put the index finger up and push and see if it hurts. Some patients hurt all the time. It doesn't matter what you test. But classically, if you test the index finger, it won't hurt or hurt as much. That's because the extensor carpi radialis longus, which is also a wrist extensor, does not attach at this point. Okay. I did mention radial tunnel briefly, and radial tunnel is compression of either the, is basically compression of branches of the radial nerve, and patients will complain of like soreness in this general vicinity, like forearm soreness, and it's usually it's like more distal and more anterior, and it's right here. Okay, and it's a very hard diagnosis to make. EMG tests are routinely negative, MRI tests are routinely negative, and it's usually a clinical diagnosis in my hands. Treatment for that is therapy. Okay, if that fails, is therapy. If that fails, is also therapy. Finally, it's after that, if that doesn't work, then I do a ultrasound guided diagnostic injection of corticosteroid. You have to warn them that if you inject there, is that they will actually have a wrist drop for a couple hours. Okay. And if they get better with that and their symptoms return, then that gives me more confidence that it's radial tunnel syndrome. That's when I do a surgical intervention. Okay. So, let's see. We did not talk about biceps pathology, but I'm going to finish this test with, okay. I'm going to finish this one test for biceps tears. It's called a hook test. So basically you have the patients in supination, and you actually hook for the biceps, but you should go from lateral to medial instead of medial to lateral, because you can have something called the lacertus fibrosis, which you could hook. So you actually go from lateral, go about a centimeter in deep, and then hook. And that's a hook test for biceps pathology. Okay. Questions or okay?
Okay, that was wonderful. Thank you.
Sure.
So we have someone asked about the Durkin's test. Could you go over that for a couple?
Yeah, great. Yeah, so the Durkin's, the question is, what is the Durkin's test? The Durkin's carpal compression test is basically, you don't compress at the level like proximal to the wrist, you actually compress where the transverse carpal ligament is. And so you take your thumb or your finger, but I usually use my thumb, and I will compress here for, it's described to compress for up to 30 seconds. But once they start feeling numbness in the finger, that's a positive test, okay? Another test that I didn't quite describe because it's not really well described in the literature, and it sounds silly, the name, it's called Federkins, right? It's like Turduncan, I guess. So Federkins is basically doing like it's actually doing a Fenlins and a Durkins at the same time, okay? It's called a Federkins. And so that's another test you could do.
How is it positive? It brings
Yes, if they have increasing numbness or paresthesias in the median nerve distribution.
after certain time.
30 seconds. But if I do it on myself after 10 seconds, actually, if I just did it and I have positive symptoms. I have carpal tunnel on both sides. I have pudal tunnel on both sides as well.
Okay, great, thank you. Can you please demonstrate how you examine for pronator Terry syndrome?
Yeah, so pronator Terry syndrome is kind of difficult. It's kind of like radial tunnel syndrome. It's a very hard diagnosis to make. And basically what you want to do is try to compress the nerve by you want to try to compress the nerve by sort of tightening the pronator. And so the way you tighten the pronator is by doing resistive pronation. And the best way to tighten the pronator teres is to have the elbow in extension, because it has a ulnar head and a humeral head. And then I would ask the patient to bring your palm down, okay, which is pronation. And I'm gonna grab their hand, and I'll say, and I'm gonna try to supinate them. But what I tell the patient is, don't let me win, okay? And I'm gonna try to bring your palm up. Don't let me win, okay? And so that's how I actually, test for pronator syndrome. They also have pain in this quadrant. There's a test called the 9 test. There's basically 9 quadrants that you could push to see if it's positive. That's another way to also test for that.
And the pronator test is positive with weakness and pain, or just weakness? Or
Sometimes they have paresthesia, and sometimes they have weakness, depending on how severe the compression is. It's an extremely hard diagnosis to make.
Okay, any other tips for distinguishing a cervical radiculopathy versus carpal tunnel syndrome besides the testing?
Yeah. So it's funny because I actually have a C6 impingement right now. And I know, and I also have carpal tunnel. And so if I do like provocative tests, right, and nothing is positive, but they're still having numbness, then I think it's cervical, okay? Also, if you have cervical spine pathology, especially C6, this is C6, they actually have numbness in the back of their hand, which is not the median nerve distribution. I currently have numbness here. I don't have numbness in my palmar side, actually. And so that's usually what I think. And then I also asked them about neck pain. Do you have neck pain? And if they say, oh yeah, my numbness goes this way from the shoulder down, that for me is also cervical pathology.
And how about if they have biceps or higher weakness?
Yep. So a lot of times when they have radiculopathy, they're still strong. And so unless it's like advanced, and so you could do the whole neuro exam, C5, C6. You could do the entire shoulder and elbow neuro exam, but a lot of times radiculopathy, at least in the early stages, their motor is really strong.
Thank you. Okay, do you ever see hand swelling with carpal tunnel syndrome? This viewer has a patient with classical symptoms of carpal tunnel, but also swelling.
Yeah. So it's not like a classic symptom of swelling, but I never dismiss any of this because, like I said, pain is not like a classic symptom. But if they have swelling and it's classic carpal tunnel syndrome, I'll still, I don't dismiss it, but not very, I would say very infrequent that I don't talk about it.
Thank you. How long do you see the hypopigmentation last after a corticosteroid injection?
Up to 1 year, or it could be permanent.
And then, do you feel that any trigger fingers are occupational, arising out of the course of employment? Based on your causes, it didn't appear so, but this person sees many administration folks with primary typing activities who report trigger finger as work-related. A few lab medicine folks who pipette, some RNs with frequent tearing motion to open soft. So your thoughts on
Yeah, my thoughts on that is that it's a. I mean, I think there has to be some sort of contribution, but it's hard to prove. And so I don't say, I don't say that trigger finger cause of the job is job related for like workers' comp, And so, I bet there is some correlation, right? If you don't move your fingers, right, as much, you don't get as much irritation. I think there is a correlation.
Thanks. Okay, one more. What are the exam findings for mallet finger versus jersey finger, please?
Yep. So mallet finger, they jam their finger and they will actually come with this posture where it's sort of bent. And then what you do is ask them to extend, right? And they won't be able to extend. They'll just they're stuck like this. So that is a mallet finger, and you get an x-ray to make sure it's not a bony mallet. A jersey finger is, so the way you test it is the flexor digitorum profundus attaches. That's the only tendon that attaches that moves that flexes the DFP joint, right? So what you do is you isolate it, you grab proximal to the DFP joint and have them flex. Okay? You have them flex. And so if they can't flex, for me, I have to rule out jersey finger. It's not always a jersey finger. I've had patients, they jam their finger and they just feel that pain, they can't move, right? In those cases, I'll get an MRI, a stat MRI, or I'll get an ultrasound just to prove that it's not a jersey finger.
Okay, one more. Can you please repeat the questions? I'm not.
Okay.
Can carpal tunnel syndrome recur after surgery?
Can carpal tunnel recur after surgery? And so I'm going to actually expand that question and say there's two types. Like after you do the carpal tunnel surgery, this is what I usually tell patients. When I do the carpal tunnel surgery, if you have baseline numbness, that may or may not get better. It may take up to a year to get better. And so just because if you just judge by your baseline numbness, that may give you a false negative or false positive in terms of failure of surgery. What does get better is a nighttime awakening. That gets better pretty reliably. You could have a carpal tunnel that never got better if it was not completely released, or you could have recurrence of the carpal tunnel syndrome. So if we do a carpal tunnel release, you never got better, right? You keep waking up at nighttime, and your numbness is the same. It could be because you have an incomplete release. If you actually do a carpal tunnel release, and then you get better for like 6 months and it comes back, then yes, it could recur. And usually I quote about 70% recurrence risk with carpal tunnel releases.